The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everyone, and a very warm welcome to this latest in our e-remedies series, a series of webinars that DDU is putting on for you. We want to give you an hour's CPD. It's going to be available on the website for you later on, and we put it together in this format in recognition of the fact that people up and down the country have very busy lives in practice. The timing of it has been to take that into account, and we're delighted to see that so many of you up and down the country have been able to join us this evening. We're going to have the opportunity for you to interact with us, to ask some questions, particularly at the end, but we'll be showing you a scenario right from the beginning. If you look to the right of your screen, you'll see a little dashboard console there. After it's been inactive for a little while, it'll sort of minimize itself. You can reactivate that by clicking on the red arrow, and the instructions will be quite apparent. So a very warm welcome. Look forward to interacting with you this evening as we go forward. We'll be working together for about an hour or so, and mercifully for you now, I'm going to disappear from your screen and we'll take on the presentation itself. So here we are, and here we go, and here's the first slide coming up. And importantly, the title of the presentation was carefully chosen. The word valid is incredibly important. Some of you will have grown up with the term informed consent, and as we go through, we'll explain why valid is really crucial and very important, why we've moved on from informed consent. For consent to be valid, yes, of course it must be informed, informed by means of a two-way dialogue, information given and information received. It must be voluntary, and the patient must have the capacity, primarily the understanding, such that they can understand the information that's given to them. So as we go through the evening, we're going to consider a number of topics and titles. We're going to look at the legal and regulatory background. By the way, this is intended to be primarily a practical seminar or webinar. Yes, of course, we're going to look at some of the academic background that explains and underpins consent, but you know, this is very much a living, breathing topic that we all deal with day in, day out in practice, and it's something that you'll have dealt with today within your busy day in practice. So not intended to be academic, but we'll touch on some of the background to it. And we'll look at patient capacity, patient authority to consent, how we communicate and what information we need to give, other aspects of consent not directly related to treatment. Record keeping will be sort of interspersed throughout, and we're going to consider an illustrative case example, and finally wrap things up with a summary. Now, going back to the case example, I'm going to give you a brief taster of that just in a moment, so that you can have a look at what it is that we're going to ask you about at the end, and the case scenario that you can constructively sort of interact with, and then you can carry this with you throughout the presentation, so you can apply the information that we give you to this scenario. And just so that you can have a little practice with the dashboard and with the interactive kit, we'll ask you a very simple question in a moment when I've shown you the scenario. So here comes the scenario, and I'll just give you a couple of minutes to read that, and then we'll ask you a poll question. So hopefully everyone's read that now and absorbed the key points. So I'm going to give you a simple poll question that you can interact with, simple yes or no question. Just simply, we're going to ask you whether you identify with the types of issues here that you've seen in practice. So here we go. And the poll is now open. And I think we can say that that's very much a resounding yes. So these are the sorts of questions that we do see day in, day out in practice. So hopefully we can give you some solutions to those questions as we go through the presentation. So let's start off with a definition. What is consent? We all think we know what it is, but it might not be that easy for us to necessarily define. So let's have a look at a useful definition. And give you a minute again to read that, but we've highlighted one or two of the key words there for you. And naturally enough, consent must be voluntarily given. The word continuing there is absolutely key. Continuing is crucial, and it's often misunderstood and indeed overlooked. Consent is a process, it's a continuum and not a one-off event. People often say, well, you know, the patient signed my consent form, so all is well with the world. But consent can just as readily be withdrawn as it can be given. So throughout what we look at this evening, please think of consent as a continuum, as a process. The other thing there right at the very end is it says not under any unfair or undue pressure. Now that might not be pressure in the sense that we think of it as coercion or anything like that, persuasive pressure. It might be as simple as a lack of time, and the time pressure, as we'll see later on, can be quite a significant factor in influencing whether we have valid consent or not. So why is consent important? Well, it's a fundamental principle of ethical practice. It's a fundamental part of good practice. It underpins what we do, and quite simply, it's a very good way to avoid complaints as well. Sound consent processes can certainly help us on the way to avoiding complaints, as we'll see later on. But it's one of the ethical principles of all health professions, and we ignore it at our peril. And as you can see from that quote there from 100 years ago, it isn't something new, and it's certainly something that's been under consideration for some time. So what are the different types of consent? Well, as you'll probably be aware, we can have implied consent. Well, what do we mean by that? Well, implied consent may be, well, you're a dentist or a dental professional, patient's a patient, they make an appointment, they turn up at the practice, they sit in your chair, they booked an appointment for a dental examination, you're holding a mirror, they open their mouth, and they may well have impliedly consented to a dental examination. And that's what we mean by implied consent. Clearly, simple courtesy may well go beyond that, and rather than just diving in there and carrying out the examination without so much as a by your leave, I'm sure we'd further explain to the patient what we're about to do and what we're about. And indeed, there are a number of cultural issues that increasingly we're becoming culturally aware that we need to bear in mind. But implied consent is generally the patient clearly and impliedly indicating to us that they understand why they're there and what's about to happen. Now, express consent can either be in written form, and we'll deal with some specific cases where it needs to be written, or it can be oral. So that same patient, we might do our examination and we might say, you need a scale and polish, this is what it involved, is that okay if I go ahead and carry that out for you? If it's a regular patient, then of course that patient's going to jolly well know what's involved, and you can be confident about that. If it's a new patient, I'm sure you give them a great deal of detail as to what's involved. But that's express consent. Oral express consent is entirely valid, and you would your records would reflect the fact that the treatment that you carried out. Written consent, we'll see a situation shortly where that's specifically required. There are certain circumstances where the GDC specifically requires us to have written consent, and there are certain circumstances where indeed it would be very prudent to have written consent. So what happens if we fail to gain valid consent? Well, firstly, we may indeed be subject to criminal proceedings. Treatment without consent could leave us vulnerable to a charge of common assault or battery. If we have a civil litigation situation, we may be considered to be negligent for having failed to obtain valid consent, and in such a circumstance the remedy, the tort remedy, would be damages paid to the patient. And of course, importantly, as we're all very much aware from our reading of the standards guidance, our regulatory body, clearly in our case the GDC, sets out in standards for the dental team precisely what we're expected to do and the standards we're expected to meet. And clearly, again, as we'll be aware, a failure to meet those standards could lead us vulnerable to fitness to practice proceedings, and indeed we do see heads of charge or allegations against our colleagues sometimes which set out a failure to gain valid consent. So it's something that we do see in the day job at DDU. And this is an interesting quotation here. Just give you a second to read that and to sort of take that in, really. I think really it gives rise to sort of quite a humbling thought, really, and I think it reminds us of the trust that patients put in us. There's a huge chasm of knowledge, if you think about it, between an understanding between us and our patients, and it's incumbent upon us to sort of fill that gap and close that gap as far as we possibly can to mitigate this discrepancy in knowledge by informing the patient to enable them to make a decision that's in line with their wishes. So because of that trust situation, in circumstances where patients think we've abused or breached that trust, there can be a perception that you know, we've very much gone against their wishes, and a patient who's very much on our side to start with can very readily become a vociferous, determined and focused complainant, indeed, you know, almost a crusader. So I think we carry that with us. It's both a burden and a blessing that we have as professionals. Now, while we're not going to focus entirely on the academic or legal basis, there'll be a couple of cases that we'll talk about that give rise to the sort of basis for where the professional guidance is and where it's come from. And I think most people will be familiar with two cases separated by around 60 years, first being the Boleyn case and most recently the Montgomery judgment. How did we get there, and has this changed anything in terms of the way we practice? Because much has been discussed about this and much has been said. So Boleyn principle or Boleyn test, as it's often known, and I think most of us are familiar with this, and it really says that, you know, if a reasonable body of medical men and you know, remember it was 1957 that this was said, but of health professionals, I think we could substitute that, would have acted in that particular way, then we're not likely to be justifiably criticised. Now, I think we accept now that that sort of doctor knows best test is somewhat paternalistic, and there's been a shift away from that. So let's have a look how we got away from that paternalistic situation in Boleyn in 1957. Well, Sidaway modified Boleyn in that simply it said that the courts have the right to find that a responsible body of medical opinion may be unreasonable in failing to warn a patient, and therefore that negligence would be shown. As you can see, it took some 30 years to get even to that stage, and that was a very limited and considered movement away from Boleyn. In Belitha, the judge said that the judge would be entitled to choose between two bodies of expert opinion and reject one which was considered to be illogical and indefensible. But even then, that was said to be unlikely to be happening other than rarely. In Pierce, the Court of Appeal asserted that when asked of a risk, the reasonable doctor would be required to tell what a reasonable patient would expect to know. So you can tell we're rapidly moving towards the position we're at now. And in Chester, not too long ago, it was asserted that the patient need not demonstrate that the resultant harm was due to a failure to disclose the information, and in that case the right of the patient to make an informed choice was discussed. So I think those latter two cases have influenced and informed the current professional standards, not just at the GDC but also at the GMC, I think, and to a great extent that guidance was rather ahead of the game. It was somewhat ahead of the law until in came Montgomery, which some of us will be aware of. So it's a Supreme Court decision. By the way, that timeline that you saw earlier, that really is dealing with the common law, and the common law, as we know, is it's the part of the law that's derived from custom and judicial precedent rather than from statute. So earlier decisions can have an effect on future cases, and the higher the court, the more persuasive the decision is. And that's why Montgomery, of course, is an important decision. So it was a case in Scotland. It was an obstetric case. Most of the cases, by the way, the leading cases are medical, and our medical colleagues are the ones who obviously dealing with situations where they have to wrestle with this perhaps rather more than we do. But this is what was said in Montgomery. And again, some of you will have seen this already, but I'll just give you a moment to read through that. And again, let's pick out a few key words for you. One of the first key words is the word material, and we'll consider materiality just in a moment. It sets out that just there, but we'll look at some practical examples of that. And it's the reasonable person in the patient's position, or if the treating clinician should reasonably be aware that that particular patient would be likely to attach significance to it. And that's where it starts to become rather more complicated and rather trickier. Let's have a look at materiality of risk and see what we mean by that. And I'll give you perhaps an example that we all would understand on a day-by-day basis. So it's not the percentage risk of a complication or of harm occurring. These are the factors that determine the materiality of the risk. So the nature of it, the effect that it would have on the life of that patient, and the importance that would be placed by that particular patient, not only of achieving the benefits of the procedure, but of the risks associated. So perhaps an example that we might consider in practice is, I wonder how many of us would routinely warn one of our patients of the risks of, permanent numbness from the giving of an inferior dental block. Probably not many, I would suggest. And if we consider that situation now, but we now know our patient to be a world-renowned flautist with one of the Philharmonic orchestras or whatever, and then we now consider whether that risk, small though it may be, would be material to that patient, I think we can start to see that we may well want to warn that particular patient of that particular risk. And it starts to become very difficult. How much do we need to know about our patients? How much must we find out before we're in a position to gain valid consent? And these things haven't really been tested to destruction, so to speak, because this is a pretty recent case. But we'll see the GDC guidance shortly, and we'll have a reassuring indication, I think, that most of us will be on the right side of the line in this already. I think one of the key things is that quite often, when we're undergraduates at dental school, the social history aspect of our history taking is is very much stressed, and it's very easy to see that go by the wayside in busy practice. But I think this brings in the importance of knowing our patients, and as one of my tutors once said, never treat a stranger. Really quite difficult when one's running an emergency clinic on a Sunday morning or whatever, but I think what it means in practice is that we find out as much about our patients as we can that has a bearing on the immediacy of the treatment that we're about to carry out. So the assessment must be both fact sensitive and sensitive to the characteristics of that particular patient. I think that sums that up quite nicely. So GDC guidance, we all know we've got the standards set out in Principle 3, and patients expect GDC standards has the 9 principles, but it also has a number of patient expectations. I think there are 32 in there, 1 for each tooth, and we can't delete 4 if there are no wisdom teeth, I'm afraid. So patients expect to be asked for their consent before treatment starts, not unreasonable, one would assume. And again, GDC in standards, a must means a must, a should is a must other than exceptional circumstances, but this is a must. We must obtain valid consent and that patients understand, and importantly, as we said at the outset, it's a continuum. This consent must remain valid throughout each particular stage. So what about capacity and authority? Well, the Mental Capacity Act in England, and we'll see the difference in Scotland shortly, set out that patients need to be able to understand, retain, weigh up the information, and importantly communicate their decision to the clinician. And the situation is both time specific and decision specific. So certainly some patients would be in a position to make decisions about certain items of treatment, and we'll talk about Gillett competency in a minute, but maybe not so much for others. So time and decision specific. And importantly, no one else can consent on behalf of an adult who has capacity. So what about adults without capacity? Well, as I mentioned, in England and Wales, it's the Mental Capacity Act that guides us here. And capacity is assumed unless otherwise established. So what we must do is take all practicable steps to help our patients make decisions about their treatment before we conclude otherwise. So that's really very important. And the Mental Capacity Act sets out that if people have a disorder or learning difficulties, that's not of itself grounds for deciding that the patient does not have capacity. Patients are entitled to make unwise or even irrational decisions, and again, it doesn't mean that they are without capacity. So the Act essentially says that, as we said in the previous slide, patients need to understand the information relevant to the decision, and they reasonably foresee the consequences of their choice one way or the other, and indeed of failing to make that decision, that they can retain the information, weigh up the pros and cons, and communicate that to us. And the capacity, as we said, being time and case specific, that capacity can vary depending on the complexity of that decision. Now, in Scotland, the Act is the Adults with Incapacity Act, and that sets out, its primary aim is to protect people who lack capacity, and to assist them really in making particular decisions about their own lives as far as they're able. And this applies to everyone over 16 who lacks capacity to make some or all of the decisions for themselves. So what about children and young people? That's often something in practice that we have a few dilemmas about. Well, in England and Wales, that's governed by the Children Act 1989, and it's capacity, not age, that's the key point. So some young people under 16 may be competent to give consent, And the question we need to ask ourselves is, does this particular child have capacity? Are they mature enough? Are they able to understand what's involved and to weigh up all the pros and cons and the information and the nature and purpose and the consequences? And it's incumbent upon the clinician to decide if what they are, they're what we would call Gdc competent. And again, that's going to be case specific, isn't it? We might well, on a common sense basis, and when we're asking seminars about this and we put the different situations to colleagues, people find it pretty easy to determine how far they'd generally be willing to go on a Gdc competence basis. So, child coming home from school, 14-year-old pops in for their routine examination. They've been coming for years. Parents know they're coming. They're able to decide they're willing to have that examination. Then I think the vast majority of us would be quite happy to carry out such treatment. At the other end of the spectrum, we're not likely to carry out, irreversible treatment such as, orthodontic extractions, etc., without going through a very much more, detailed information process and involving the child's parents wherever humanly possible. In terms of who can have legal parental responsibility, it's a pretty complicated situation actually, but it's simplifying it as far as we possibly can. Mothers automatically have legal parental responsibility, both parents if they're named on the birth certificate, and that's from 2002 in Northern Ireland, 2003 in England and Wales, and 2006 in Scotland. And prior to that, essentially, if they were married or had an agreement registered with the High Court. So in summary there, Gdc competence depends really on maturity and their ability to understand that situation. In terms of refusal of treatment, that's quite interesting. It's pretty complicated in England, Wales and Northern Ireland, and in such a circumstance of a 16-year-old refusing treatment, I think you'd be holding fire unless it was something very, very urgent, and you'd be contacting us for some advice on this. But essentially, theoretically, adults with parental authority can override a child's refusal, but in practical terms, I think we'd be struggling to deliver too much treatment on an unwilling 16-year-old. And in Scotland, the position is different in that parents can't authorise treatment that a competent young person has declined. So here we are. We're in our practice. It may well be a situation that many of you are sort of sitting in and looking at right now and right here. And, on our wall, we've got this GDC poster that we're obliged to display. And I think what that does mean is that patients are aware of the principles that we must follow, and indeed in complaints they're quite ready to quote them back to us. And if you look at Principle 2, it requires that we communicate effectively with patients. Principle 3 is obviously obtain valid consent, but I'm flagging this up really so that you're aware that the elements of valid consent aren't solely contained within Principle 3. So Principle 2 sets out very clearly that patients expect full information, clear expectations, details of the cost, communication that they particularly can understand, and they want to know who's carrying out the treatment. So we must give patients information they need. Standard 2.3.4, you can read these at your own leisure, but essentially it says that you should satisfy yourself that patients have understood the information you've given them, for example, by asking them questions and asking them to as we were taught at dental school, to reflect back that information to us. 2.3.5, often a tricky one in a busy practice, but we need to make sure that patients have enough time and enough information. So enough information and enough time to ask the questions. That's sometimes a real challenge in a very, very busy practice, but we need to be mindful of it. 2.3.6, and again you can read these yourself, but it requires that we give patients a written treatment plan and that we ask them to sign it. So information there very clearly. 2.3.7, again, within that treatment plan, the detail of what needs to be included. So the proposed treatment, realistic indication of the cost, and whether that's on an NHS or a private basis. And all of these things we need to update if and when there are changes. A cheery statistic for us, I think. This is something that Ipsos Mori, it's GDC, did some research, or Ipsos Mori did some research for and on behalf of the GDC. And 83% of patients polled think that most dental professionals are putting their interests first. And I think that's a heartening statistic in these days when all we hear about is claims and GDC complaints, doubling every 3 years, etc. The vast majority of our patients believe that we are acting in their best interests. However, that goes back to that trust burden that I mentioned earlier on, and as I say, we take that for granted at our peril, I think. So we're back to our surgery wall now, and we've got our poster here, and let's have a look at some more things that this required of us. Talking about record keeping, standard 3.1.2 says that you should document the discussions that you have with patients in the process of gaining consent. I can't stress this too much. We don't need to write War and Peace in our records, but it's really important that, particularly when we're dealing with claims and complaints and the like, that we've got some indication of the narrative of that whole consent process. How did the conversation go? What did we discuss? What were the options? What were the risks? What were the benefits, flowing from our findings and our diagnosis? What did the patient say back in return, etc.? So just bullet points as to these key points within the records can be absolutely invaluable. And as you can see there, the GDC quite prescriptively sets that out as an expectation. And it's a two-way process. Montgomery would expect this of us, but we find out what our patients want to know as well as what we think they need to know. And it's about meeting their expectations, because their perception of what they want and need is quite often different to what we understand they require. So the sort of things they might want to know are pretty obvious, but it's easy to overlook them in a busy practice. So the options, why the treatment's necessary. Again, we live and breathe dentistry, and we remember that even the most intelligent and perceptive of our patients, it's simply an alien concept to them. So we need to explain things in simple lay terms so that they can understand. So what are the consequences, the risks and benefits of the treatment? What's the likely outcome? What do we recommend? That's always a difficult question, isn't it, really? What would you do if it was your situation? What are the costs? We would never go in the restaurant, order the meal or the bottle of wine without knowing what it was going to cost us in advance. And it's something that actually that Ipsos Mori survey made very clear that patients are really concerned about that, and that adds to their anxiety if we don't give them that information. What are the options if no treatment at all is carried out, which is always a valid option. And we don't like the term guarantee, really, because it has a particular legal connotation, but I think we know that the NHS has a free replacement without charge, and I think most of us in private practice would reasonably repair or replace treatment that failed within an unreasonable time. So that's what patients need to know from us. These are really the two situations where written consent is a requirement, and that's a must look, that's a mandatory requirement. So where sedation or GA is carried out, that must be in writing, and it must be at an appointment in advance of the actual treatment appointment. So looking at the provision of bespoke information, I think this is really where everything comes to life on a practical level. This is what we do with our patients. This is where the really good communicators in practice tend to have fewer complaints, and I think this is where we can very much focus on our practical day-to-day practice. We need to recognise that there are sometimes barriers to communication, and we need to understand what they might be. Patients have different learning styles. Some people are very visual, some people like very detailed information, some people are big picture patients, and sometimes if there's a mismatch between us and our patients, that's where information can fall between the cracks, and we can find that we're having a misunderstanding, miscommunication. A couple of examples of that in a minute. So it's very important that we give information in different styles. Some examples there on your right. Interestingly, and it's very much in a more commercial world, we do sometimes see patients suggesting that very commercially biased information that's sometimes produced by manufacturers, etc., it isn't impartial, and I think one needs to exercise a little bit of caution. While it's obviously all information can be of value in that process, we need to exercise a little bit of caution on the weight that we would put on something that's produced by others. So what else? Trust. Well, you know, if patients don't know us and we haven't built up that trust, that can be a barrier to communication. Patient anxiety, there can be language barriers. We can sometimes use jargon terms that can befuddle patients. You know, if we say to a patient, your upper front tooth is non-vital, the patient might retort with, well, it's jolly important to me, and it's very simple for just that simple bit of language to confuse a patient. Sometimes information overload can be a factor. One particular case that springs to mind is that patient pitched up and had a lower 6 with a porcelain fused to metal crown on it. Tooth was TTP, patient in considerable discomfort, and our colleague explained in great detail the two key options really, which were RCT or extraction. And eventually the tooth was extracted, and unfortunately gave rise to a complaint that this tooth had been removed without consent. As we assisted with this complaint, and as the correspondence went backwards and forwards, it became abundantly clear, and the patient actually twigged eventually, him or herself, as to what had happened, that they'd simply conflated the two explanations and didn't understand that the two explanations, the detailed explanations that our colleague had given, were two completely different processes. So, you know, we might need to refer you to a specialist. Well, yes, that does apply to both endo or extraction. The crown of the tooth might fracture if I access it. Well, the crown of the tooth might fracture if I extract it, etc. And ultimately it transpired that this patient didn't know the difference between a root and a nerve, and believed that a root extraction was in fact a pulp extirpation. So, you know, we need to be very careful and make sure that our information is given in very simple terms. We said earlier that time can be a barrier to good communication and valid consent. And again, another case that springs to mind where a patient, new patient to the practice, new patient to our colleague, came in for an examination appointment, and left having agreed to and had an inlay-onlay preparation carried out at that very appointment. Having gone home, reflected upon this, the patient decided that they hadn't been given sufficient time to consider matters, wanted to change their mind, and obviously it was a little bit too late by that stage, and it gave rise to a complaint. I'd contrast that with a situation that might occur in practice where one of our patients comes in, regular patient, has had crown and bridge work or whatever with us before, knows us, knows what's going on, comes in with a fractured tooth and begs us to deal with it there and then because there's a wedding coming up in a week's time or whatever. And we might well be able to do that if our next patient is cancelled and we've got time to do it. So it's patient specific, it's case specific, but not giving patients sort of cooling off time, if you like, it is fraught, and unless it's in a particular circumstance, it's pretty risky. So let's have a look. In summary, really, our treatment should always be clearly in a patient's best interest, and that's going to vary from patient to patient, and in accordance with current accepted practice, with current teaching and practice. If we do deviate from current teaching and practice, and there might be the odd occasion where it's in the patient's interest for us to do so, it's very much incumbent upon us to explain that this treatment is not mainstream, give a clear rationale for the advice and treatment that we're offering, and we jolly well need to document that particularly carefully in that circumstance. Disclaimers, we'll often see colleagues sending in a list of disclaimer items that we see that there's a whole list of things that people warn patients about, and if we're not careful, our disclaimer list can simply become evidence that we jolly well knew we shouldn't have been carrying the treatment out in the first place. So disclaimers aren't valid and actually can be detrimental and negative. Cosmetic treatment, it's been in the news this week. You've probably seen the Royal College of Surgeons, I think it was, launching their website. What they're saying is that it's a two-stage process, and they're recommending a cooling off period. Obviously, cosmetic treatment is normally elective. We've got to be very careful that we understand what their expectations are, that they're achievable, that we understand what it is that they think is the likely outcome, and they understand what the outcome is that we're suggesting. Because it's elective treatment, a cooling off period is often a jolly good idea, and we need to be mindful that the particular wishes of the patient, there may be a real desire of that patient for a particular outcome, and it may be a barrier to them receiving some of the information that we're actually giving to them. So we need to be mindful of that and particularly cautious in approaching cosmetic treatment, and our records really need to very carefully reflect the detailed discussions that we have. Moving on and back, here we are on our surgery wall again. There are other situations where we'd need patients' authorization, patients' consent. So if we're being asked for information about patients by our third parties, then standards in Principle 4 sets out that it's incumbent upon us to explain to the patients how that information will be used. We make sure that the patient understand that, we obtain and record their consent to that, and that we disclose only the minimum information necessary. And again, that they can withdraw that permission. It's not if it's not necessary for patients to be identified, then we must make sure that they remain anonymous. And just taking that back a stage, I think one of these things, this last point here, that explain to patients that they can withdraw their permission, that has particular risks when anything is put onto the web or onto websites, etc. Because unless we can be absolutely certain that we have long-term control over that material, it may frustrate our wish to comply with that last bullet point for our patients, and we need to sort of start with the end in mind and consider where that information may go. So only in exceptional circumstances may we release information without their permission. Almost certainly you'd be in touch with us in those circumstances, and we could give you some advice. We're going now to have a look at the case discussion, and I'm going to remind you of the scenario there that we're all looking at. And once you've had the opportunity to read that information again, I'm going to give you a couple of minutes to read it through again, and we're going to pose one or two questions for you, and then we'll have a little discussion, and this is where you can certainly be interactive with us in responding to those questions, and we'll discuss some of the replies there that we come out with. So we're going to answer. Well, we're going to pose one or two questions first before we answer them. I think hopefully you've all had sufficient time to read that. I'll give you just 30 seconds more, just so that we've got that entirely clear. Maybe 15, 30 seconds is a long time. Here we go. And here's the first 2 points for you to consider. So what are the key points within that scenario, having borne in mind the points that we've looked at as we've gone through the earlier information? So what are the key points that jump out at you from that scenario, and what indeed would you do? So what are the key points? What would you do? I'll pop back to the scenario so you can see it. What are the key points? What would you do? A couple of minutes for you to send in some thoughts on those points for us. Okay, so there's some answers coming in now where colleagues are explaining that the clear risks associated with periodontal disease. Is it best just to refuse all treatment these days? Perio is unstable, we'll come to this. Is there pain and or sepsis? We'll come to that in a second. It's not clear that the patient's understood. That's an important point from Michael, and we'll cover that as well. And a key question that Anusha's raised is, does this patient understand the information we've given to them? And I think that's a really important point that we'll explore in some detail in a minute. And again, colleagues are flagging up that this patient's primary concern is cosmetic. Question here is, does he have capacity? A clear and important point. Tamas is setting out the information that he gave, and he'd say that, you know, essentially setting out the definition of oral health, that you know, teeth aren't just window dressing, that they're fundamentally important in terms of the functional consideration as well. Colleagues are flagging up NHS regs in terms of securing oral health. Thanks for that, Gary. And the consequences should be very clearly set out. So lots of info coming in there. I'm going to move forward and pose a couple more questions, some of which colleagues have alluded to in their points that are coming forward. So colleagues are flagging up here that the risks, of course, of TMJ problems, gastrointestinal problems, etc. as well. Anusha again is saying that it should be set out to the patient that the cosmetic treatment may be possible, but we need a stable periodontal situation first of all. And this patient needs time to understand the treatment that's being proposed. I think that's really important. So let's have a look at another couple of questions that might arise from this. So some of the key points are being flagged up. Not too many what you do's have come through. Can we refuse to treat if we disagree with their decision? I'll answer that in a minute for you, Jackie, and I think that's one of the key questions that colleagues would want to know. Would this differ, and that goes to one of the points that a colleague raised there, if he presented with an acute apical abscess and asked you only to treat that? So fire in a couple of points on that and let's see what we think. So would your approach differ if he presented with an acute apical abscess and asked you only to treat that? One or two colleagues are saying refer for a second opinion. Peter said yes, it would make a difference. Yes, I think you can treat the emergency. Lots of yeses coming in. I'd treat the pain. Important to get the patient out of pain. One-off emergency, I'd say that's okay. Acting in the patient's best interest. So I think we've got pretty much a consensus going on here that we can, readily differentiate, can't we, between things that we would be willing to do and willing to go ahead with, and things that it wouldn't be in the patient's best interest to do. So let's have a look at one final point, and again, one or two colleagues picked that up. So what would we do if he complained about our decision to treat or not to treat? What are the likely issues arising there? One or two points coming in already. So listen and respond to the patient's complaint. So we deal with it like any other complaint, wouldn't we really? Contact the DDU. I think you'd be very welcome to do that, Richard. And I think that's very wise advice right from the outset. And I think what you might be doing is, if you had any concerns about this dilemma as it arose, you might well be willing to contact us, be wishing to contact us for a steer. Obviously, we're not the arbiters of teaching and practice, but what we would be discussing with you is these ethical dilemmas. So let's consider the key points really in responding. Now, obviously, generally speaking, we should be considering our patient's wishes and taking them into account. And this patient has expressed a wish in the first, ignoring the abscess for a minute, in terms of just treating his anterior teeth. He's expressed a wish for us to do some treatment that we know isn't in his best interests. And I think the key point here is that we would clearly be wanting to explain to the patient, as a number of colleagues have said, the reason for our advice, and we do our utmost to explain that to them. Sometimes if patients don't take our word for it, a referral, and again a number of you flagged this up, for a second opinion might well be worthwhile, because sometimes it's the way we tell them, so to speak. Sometimes if they just hear it from a second person in a different way or in very much the same way, then they'll take it on board. Sometimes they think we have a particular axe to grind. Someone mentioned the NHS. Sometimes patients think we're reluctant to offer certain treatments on the NHS. Clearly in this case that wouldn't be the issue. It would be a genuine clinical situation. But it's important that, as well as patients having their autonomy, so too do we. And we oughtn't to be pushed into providing treatment that we don't believe in, that we don't think is entirely appropriate. Bridget's flagged up that it's important to get to the bottom of the dissatisfaction if possible, and certainly if there's a complaint there and then certainly we can do that. And if it's not there and then, we'll invite the patient back in for a chat. But if the patient refuses to have all the treatment or that you believe is necessary, or certainly the basic stuff that's important, then we respect their right to decline your treatment. A competent adult, as we've said right from the beginning, is perfectly entitled to say thanks but no thanks, and to refuse our treatment, even if we think it's neither reasonable nor in his best interests. And sometimes, that can give rise to complaints. But I'd certainly rather deal with a complaint for declining to provide treatment that's wholly inappropriate than for embarking upon something that I wouldn't agree with and I wouldn't want to deliver, embarking upon that under pressure from the patient and then having to deal with a complaint when things go wrong, because as we all know, patients can sometimes have quite short memories as to the information that we've given them. So clearly embarking on the treatment in the first instance is certainly not something that we'll be willing to do. We'd stand our ground, we'd explain very carefully and in terms, as we've said, bearing in mind all those communication factors, and we'd provide information verbally, we'd offer leaflets, we'd offer information, we'd offer for this patient to see a colleague if they wish, but ultimately the bottom line has got to be that we'd make ourselves vulnerable if we carried out treatment, and we'd be subject to criticism as to why we wouldn't do that. So we'd set out why the other work was necessary, and we wouldn't carry out treatment that we considered is inappropriate. We mentioned the disclaimer point earlier. Even in this circumstances, if we set out all the disclaimers we like, it's really not going to help us particularly. Dealing with the abscess situation, as you almost exclusively and uniformly said, of course we can act in a patient's best interest, and we can do a limited amount of treatment that they're willing to undergo that has a health benefit and a health gain for them. So I think that's a very simple little scenario, but it does raise a number of points that we come across pretty much day in, day out, really. So we're coming to the last couple of minutes now, so I think we can perhaps sum up, and we might have just a minute for any last questions that you might have. But I think my key point that I would want you to take away this evening is that consent is a process, it's a continuum and not a one-off event. We've all heard people saying, oh, I consented him or her, and I've got my consent form signed. It isn't. It's a process that begins the minute we give patients information. Arguably it even starts the minute they read the information on your website, cosmetic dentist to the stars or wonderful with children. Well, if you start to make those promises, then we might well want to have some evidence that we can back it up. We respect patient autonomy. Patients have the right of self-determination in terms of what happens to their body. You remember the Mugger quote, it's a high trust environment. I've heard that one before, but it's a high trust situation. Patients put their trust in us as health professionals to do things that no one else would be entitled to do, and we must bear that with us and bear it in mind at all times. We are required to determine their capacity and authority. Not always easy. Remember, it's case specific, and it's time specific and treatment specific. We need to effectively communicate that information. Communication being a two-way process. Do we need signed forms? Well, only in the specific circumstances we've described, although for cosmetic and extensive treatment it may well be desirable to do so. And our records are our best dental legal friend. So GDC requires that we record that process, and we're always delighted to receive comprehensive records, because it puts us in the best position to act in your best interests and to put your best foot forward and to defend your corner, to defend your position as far as we ever possibly can. So that concludes things for this webinar. We're just nicely on the hour. I'm very grateful to you for joining us, for giving up the early part of your evening, for your interaction, for your fantastic questions. This will be on the website shortly if any colleagues haven't heard this, and thank you. You got some thank yous coming in there, and I'm very grateful to you for giving up this part of your evening. Look forward to welcoming you to the next e-remedies webinar, and have a safe trip home and enjoy the rest of your evening. Thank you.